some of the more difficult issues to deal with in a series of conditions with very difficult issues. And also, I think because you people are all dealing with these problems in different levels at different stages of the conditions, I hope it's that we can have a bit of interaction, and you can feel free to sort of butt in every now and again. Although it's a bit difficult with the microphone, we might leave it till later. Okay. I'm going to start with swallowing, and first I'm going to talk about what normal swallowing is. Now, I know some of you will have a clear idea, and some of you might not have ever looked at it before. So really what you can think of as swallowing is a complex series of movements, and it's been divided up variously, and the way that I think we can think about it that's helpful is the oral phase, and I'll go through this with diagrams in a minute, which, if you keep in mind, that's under voluntary control. You can open your mouth, you can put food in, you chew it, you know what you're doing with it, you've got good sensory feedback in normal swallowing. Then we push the food into our throat, and the reflexive phase starts, but it's not reflexive as in heartbeats and things like that are reflexive, because we have sensation, so we can feel it's there, we know what's happening. And there's some voluntary control over it because of that sensation, so it's a little bit of an in-between stage. And then there's the esophagus, which is the gullet, the tube between the top of the bottom of the throat and the top of the stomach, and it's got minimal sensation. You can feel vague discomfort, but you have no idea that your esophagus is contracting or anything like that. Now, with adults, and the people who have these conditions, there's a sort of a bit of a design problem, if I could say, with swallowing, because we share the same pathway for breathing and speech as we do with swallowing. So there has to be a complex valving system to stop food going into the airway that's usually used for speaking and breathing. Okay? And that's why swallowing is one of those areas that's often affected with complex neurological conditions. Now, just to reiterate, we're just going to go over in a series of four diagrams, so that you can see exactly what the swallowing process is. Now, presumably, you'll put something in your mouth that you like the taste of. There's a whole other set of reflexes. If you put something that's too big to swallow and tastes nasty, you start retching or things like this. But here we are, we've got something in our mouth that we like the taste of. We gather it up and place it centrally on the tongue. And afterwards, when you're having your lunch, just have a little experience of this. Okay? So, we've chewed it, we've mixed it with our saliva, we've made it into a sort of a swallowable, what we call bolus. Okay, and the sides of the tongue lift up, tip of the tongue lifts up, back of the tongue lifts up, and just for that sort of split second, it's there placed in the middle of the mouth, of the tongue. Then, let me go back. Oops. Can you notice the other thing is at the back of the tongue, that bit there, the soft palate is lowered to hold it in position, and that's the air space of the nose above it. Okay. Then, once we push it back, we get into the reflexive stage of the swallow. The first thing that happens is you can see that soft palate goes up and closes the nose and the mouth from each other. And that's really important that happens, because have you ever tried to vacuum something with that little bit open on the vacuum, on the hose? You can't get good pressure. So you have to be able to generate good pressure, so everything has to close off nicely to do that. And the back of the tongue drops down, and the tip of the tongue comes up, and you start to push the food over into the pharynx. And then, at the same time, you can see this area just there is starting to elevate. And the epiglottis, which is this sort of flappy thing that when I went through speech pathology school, we didn't know what it did even. That's how where the knowledge of swallowing was when I started. I won't say how long ago. It starts to cover the elevated airway. Now you know yourself that your airway elevates because if you put your finger on your Adam's apple, or there, when you swallow, you can feel it go up, right? You just have to trust me that the epiglottis is going down. Okay, you can see that Adam's apple area is elevated and closed right off, and the epiglottis has come down, and the food is sitting there in the back of the tongue. And then the pharyngeal wall, that area in front of the spine, then contracts and pushes it through into the gullet to go on its merry way to the stomach, we hope. I don't know what that's... I'll just get rid of him. The HP system. Okay, so you can see from those few diagrams how complex swallowing really is. So it's not surprising that it can break down quite seriously. Now, in these conditions, and I think you've probably had some lectures beforehand that show these conditions are often not as clearly diagnosed. They're not, the pathway is not as clear as it might be when you read a pamphlet. I don't know what's happening there. You can have problems affecting the oral phase, so we're talking about chewing, mixing food with saliva, centering food on the tongue, the pharyngeal phase, where it's protecting the airway and pushing the food towards the stomach, or the esophageal phase, where it just goes that bit, where it goes from the lower pharynx to the top of the stomach. All of those areas can be differentially affected. And it can be affected in different ways, because you could have muscles that are uncoordinated. And you can see, say, with MSA, where it can start as what we call ataxia, so that there's an incoordination of movements one to the next. The sequence doesn't flow. So you can have that type of problem. Or you can have problems of slow, weak muscles. So what happens when somebody goes to swallow is the larynx doesn't rise as much because there's not as much muscular contraction, that sort of problem. So it can break down in lots of different ways at different points in the swallowing process. And it can, in some conditions, you can have a bit of everything just to make it complex. And you can see that the main complications can be malnutrition, dehydration, and aspiration pneumonia. And I think Jim talked about some of the consequences of that. And I suppose it's where the issue is, it's where you are in that process, how you deal with it, what your response is. Now, aspiration. This is an X-ray photograph. The black stuff is fluid. I think it was fluid from memory, and you can see that it's settling in the lower pharynx. It's in that area above the epiglottis, that little flipping thing at the back of in your throat. But what's happened here is that that airway hasn't closed off properly and material's gone down the wrong way. And that is what causes aspiration pneumonia. And some people can get aspiration pneumonia very quickly after one event. Other people, they might just aspirate a little bit at a time. Their body seems to cope with it. They can cough, that sort of thing, because coughing, the other part of aspiration is our body's response to it. most of us have experienced aspiration at some point, even if you're just talking while you're eating. Kids' birthday parties are a good source of aspiration, that sort of thing. So most of us know what it is. And our usual response is to cough, 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 cough. And that can happen in these conditions too. Sometimes, though, there's a sensory loss and there's not a cough response, so we silently aspirate. And it can be sometimes something that's sommate. One builds up after time and a chest infection might suddenly appear, even though the they've just reached that tipping point that their body can't quite cope. So pneumonia, when I say aspiration is a risk for developing pneumonia. There are other reasons why you can develop pneumonia too, but aspiration is a pretty important one. Other things that contribute to developing aspiration pneumonia, poor oral hygiene. Because if you think you've got dental infections and things like that, you're aspirating some fairly nasty bacteria. So oral hygiene is actually an important thing that you can do. Dependence on feeding is another factor that can cause aspiration pneumonia. Part of that is, there's an aspect of swallowing that's very important, and it's called the anticipatory phase. And you can see it in small babies, birds, whatever. As food comes towards you, you open the mouth, you also cease breathing. So you don't want to be breathing in while you're swallowing. So your body at a subconscious level adjusts to the food coming towards you. Now, because we've been feeding ourselves for a very long time, we get a sort of an automatic motor pattern for as we put the arm up to the spoon, with a spoon or fork into our mouth, our breathing pattern changes. Sometimes when people are being fed by other people, they're not getting that feedback. You can be fed at the wrong pace. You can be not concentrating in the same way, not getting that feedback. Another thing that I haven't written up there is just physical immobility. So if you're walking around, you're much more likely to be clearing your lungs and have a cough and that sort of thing than if you're in a situation where you're dependent and stuck in bed. So it's important if you're starting to cough, or if you're having choking episodes, or if you're finding it difficult to swallow, to let people know, so that we can, particularly in the earlier stages of the condition, do some things that might make it safer. That's what we can't cure swallowing problems, but we can do some things that will make it a bit safer, at least for a period of time. And as I said, aspiration can occur silently, so as you're swallowing, it can go down the wrong way and you don't know it. You don't cough, you don't get that cough response. That's what it means. So what sort of things do we do? Some of them are very simple, but we know they work up to a point, as much as anything works in this condition. So the reason you might get thickened liquids, and I have a sort of a policy that I only put people on thickened liquids when I've seen that it actually helps, and that I thicken it to the minimal amount that helps, so that it's not like pudding unnecessarily. But what does thickening fluid do? It makes it flow more slowly. So those tighter, slightly weaker muscles have more time to respond, to elevate. Okay? Soft, moist foods are usually better too. Some of the medication can be drying, sometimes in these conditions, and sometimes you just have a drier mouth anyway. So that if foods are moist, soft, don't have to chew them so hard much, and they're easier to form into that bolus on the centre of the tongue. So the things that are hard, difficult, are dry, particulate foods that crumble in the mouth, and I'm thinking of sort of like flaky pastry, things like that can be hard. And highly textured foods that require a lot of chewing, like meat. You can have meat, but it's often better if it's cooked nice for a long time in a stew, that sort of consistency. I haven't said here, but I should, that taste is very important for how well our swallow reflex is set off. And I've seen people with terrible swallows who can, if they really like something, can sometimes swallow it. And that's important too, because there's nothing worse, and I think that's one of the problems when people go to hospital, dare I say, that they get this sort of plate of grey blobs and green blobs and white blobs, and it's not very appealing, and so it doesn't prime the swallow reflex, makes swallowing even harder. So that's an important issue, and I know you don't have to have a swallowing condition to not be able to eat something that is fairly unappetising. Medications can be really hard. Some people without any neurological condition have difficulty with medications. Anyway, that's probably, I don't know what percentage of the population, but it's probably about 20% of people gag when they try and take pills. And remember when I said there are protective reflexes, somehow some people when they put a pill to the back of their throat will gag because they're setting off something in their mind that this doesn't taste nice, it doesn't feel nice, and it's hard to swallow. Having said that, what you can do if you take medication, it's much better to put it in a puree so there's not too much difference between the range of textures. Water can be really hard because you've got water running quickly down the throat and the pill sitting there. And sometimes we can have to take one drink of water after the other, and the pill sitting there. So even quite early you might want to do that. Okay. Sitting upright is very important. Again, anybody try lying down and swallowing, really hard. So somebody who's got a compromised swallowing mechanism, lying down is usually really hard. Occasionally somebody's a bit different, but by and large I'd say 95%, 98% should be sitting up, but also comfortable. Because if you're in an uncomfortable position, the whole muscle tone rises and you haven't got the right background to move against, you're tense. One of the issues with a lot of these conditions is that GORD or gastric reflux, which is highly prevalent in the general population over about 60. But it is one of the features of some of these conditions. The autonomic problems begin. So sit up after your meal. Don't have a large meal and immediately lie down. You're asking for problems with aspiration. And make sure that the doctor's looking at managing reflux as well, just not seeing everything in a neurological way, that the reflux is being managed too, because that causes a lot of problems within the normal population. General population have problems with that. And I work in a dysphagia clinic that is just for largely people coming from their GPs, and I would say about 50% of people who complain of a swallowing problem up here have reflux. The other thing is don't have extended conversations. I think for people with a swallowing problem, one of the hardest things is dealing with the social elements, the social aspects of mealtime, because traditionally that's where we sit down and talk. However, you really need to separate those two things out. And if you think of how families come together and eat. And it makes it very hard for somebody with a swallowing problem. Sometimes I recommend that the person eats most of their food before the family get there, so they can just have something that's easy to swallow and they're not pressured into feeling like they have to eat the plate, to empty the plate. They can enjoy the company separate from the meal. So don't rush meals, take moderate-sized mouthfuls. That's something that's very individual. Some people need enough in their mouth to set off the reflex. Some people need a very small amount, that sort of thing. And clean teeth after meals. I think that must be the school bell. Take small sips every now and again, so you're encouraging yourself to swallow often, or the person to swallow often. There are some medications, and without going into them, they're not easy. There's not an easy answer. You can get medications that will dry up secretions. Sometimes they only work for a while because your body adapts to them, your salivary glands adapt to them, and they'll start producing saliva at its old rate. If you are taking those medications and you think, oh, they're not working, and suddenly stop, because your receptors in the salivary glands are used to that level, you can then have absolute floods of secretion. So if you get on one of those medications, start slowly and stop slowly. Don't suddenly stop those medications. And some of the medications that you might have been given for other things can work that way too. Botox injections, the ones that people have in their face, are sometimes put in salivary glands to decrease the amount. The other aspect of that is saliva is really important. So although you might think you've got too much, you might then find it's hard to swallow because you can't add saliva like we do to our food. Now, if you think of the sort of main salivary glands are just on the side, the ones that would come up with mumps. And they're nestled between muscles that work when we're chewing, and they're actually stimulated by chewing. And so as we chew, it's actually quite a good design. I was a bit rude about how we designed. It's quite a good design feature with our salivary glands. They squirt out saliva onto our second molars as we chew. And we chew up the food and we mix it with saliva and make it nice and moist. So if you go ahead and cut out saliva, you can have some consequences in swallowing. So it's a bit like everything else. It swings and roundabouts. The other problem that if you've got your own teeth, in particular, that if you don't have as much saliva, saliva is also protective of the mucosa and the teeth. It's got some antiseptic type properties that are quite important, and people can get very poor dental health as a consequence of stopping saliva. Now, having said that, you can also get a dry mouth, and that some of the medications can cause a dry mouth. What do? And you have to stop and first thing to do is get your mouth, as I've just said, is at risk of being damaged. It's not being protected by saliva. So get a soft toothbrush and toothpaste. Don't use Listerine or anything that's very strong. Mild is the way we go. Whereas rinse your mouth with water so that the mouth gets rid of any sort of chemicals. Frequent sips of water or crushed ice. There are artificial saliva products like biotin or grapeseed. And the last thing I'd like to say is you can have a dry mouth and pooled saliva at the same time, particularly if your mouth isn't moving very much. So you have the problem of the mouth feels incredibly dry because your tongue is not moving and it's not spreading the saliva around. It just stays on the bottom of the mouth, so that people will complain as to how can he or she complain of having a dry mouth when they've got too much secretion, but it can happen. It's because of that lack of movement. Okay. Now, before we go on to communication problems, are we travelling all right for time? Yep. Okay. I just want to show a couple of videos so that you can so you can see how important saliva is, or swallowing is, how quickly it happens. Just let me see if I can find it. Just bear with me. Okay. Now, I'm going to show you, I think, a normal swallow first. Okay? And I want you to notice how quick it is. This is nectar consistency, right? And that little bit, you can see the structures that I talked about. Can you see the little epiglottis that flips over to cover the airway? And this space here is the top of the airway that closes off as we swallow. So we can just see how quick it is. And I think it's important to understand. I don't know what I've done there. Okay. Now, I think. That's a normal one too. Again, a quicker consistency. And again, you can just see how that closes off very quickly. Now, I want you to watch down in this area because you can see that it gets air filled. It's a bit hard to see, isn't it? That one. I won't worry. I won't persevere. We'll go back to communication. Communication problems. Now the first sort of communication problem I'm going to talk about is dysarthria, and you've probably heard these terms, or the main of it, which is primarily a motor speech problem. So it's about the muscles and how they work to speak, for speech. Okay. Again, in these conditions, there are various combinations, and my experience is that one person, although there are some similarities and people group together, people present differently. And some people will not have the speech problem early, and it may never develop to be, well, usually, eventually it will develop, but it may be very slow developing. Other people, it can happen quite early. So that's the important thing. You're going to be probably different than the next person, even though you've got some signs and symptoms that are the same. So it can be incoordinated, which is sometimes called ataxic, and that's really an incoordination of one sequential movement after the other. It can be hyperkinetic, which is really the muscles overshoot and undershoot, so they're not smooth. It can be tight, the muscles can be tight and what we call spastic, where the muscles don't stretch and contract normally, they're tight. Or it can be hyperkinetic, where they tend to be rigid more than tight. Okay? And again, with some of those conditions, you can have a bit of everything just to make it complicated. How does it present? Imprecise. consonants is usually the first sign. So some people say, oh, I sound like they're drunk. If you haven't got enough strength to make a sound, you can't. I'll give you an example. Say I wanted to say t, right? A very common sound in English. What I have to do is put the tip of my tongue and I have to hold it tight for a millisecond and let the air build up behind it, and I release it. And it's called a plosive sound because it's a release of a puff of air. Okay? Now, if your tongue is tight and has reduced range of movement, I can't get that, and moving slowly, I can't get that. I can approximate it like that sort of thing, but I can't get that quick, firm sound. And that's one of the signs that you can see quite early in some of these conditions. Hesitant speech. The speech people might have trouble starting something, and so that they might know where their articulators are, their brain's not telling them quickly enough where their tongue is starting from. Because say I want to say t again, in a subconscious level, my brain has to know where my tongue is to start with to know to move it up, right? Now, if you haven't got that feedback, you can't, you grope a little bit, you're hesitant, you have to put more effort into that. And sometimes speech can come in short rushes and hesitancies. Low volume also. You haven't got a good air supply. Tight voice is another problem. Then there are other problems. There are more language-based problems. And so it might be that there's a difficulty, and this happens more particularly in later stages of the disease, but it might occur more often in, say, corticobasilar syndrome. It's more likely to occur early in the disease. They vary. So sometimes it's effective. What I see more commonly is that there becomes, as the disease progresses, a difficulty initiating conversation. So the conversation partner becomes quite responsible for introducing, for saying hello, for introducing the topics, for changing the topics. And although the partner, the person with the condition, is quite able to respond, they might not think to say anything, and that can be quite a hard one. Sometimes vocabulary, spelling, reading and writing difficulties may develop, or difficulty with complex comprehension where you have to process a lot of things. And you can imagine if somebody has difficulty speaking and being understood, people rush to give a pen and paper. Now, it might be useful, but it might not. It's a very individual thing. You need to sort that out so that you're not putting unnecessary, or get a computer. You know, I've heard people say, oh, why don't you buy them a computer? It's a lot of, if you're unwell and struggling to do very simple things, spending time learning a computer is not necessarily going to be the answer to all the problems. But with all, I think it's sort of done with the best intention, but it doesn't always work. Sometimes there are computer systems that will work for some people quite well. I'm not sort of poo-pooing it, but I think it's an individual thing. And somebody like who comes from sort of an elderly person who's never had a computer before in their life, I think it's a little bit late when they're quite unwell to start learning. They're not going to do it terribly well. Okay, as I said, corticobasilar syndrome is more associated with language problems than the other two conditions. And in that condition, it's difficult to transferring. It's not so much a motor system, but it's a motor programming problem at a higher level in the brain. And reduced complexity of language may be present as an early sign in this syndrome. And with that goes writing problems and reading problems, which makes alternative methods of communication difficulty. So what do you do in this? I mean, there's not a magic answer to it, but I think it's important that people don't withdraw and stop communicating, that you make opportunities for stimulation so there's something to talk about, that you go out and you see things, even if it's putting aside time to watch a favourite television program together so that you've got that as a shared experience. So don't withdraw. Or perhaps sitting down and reading bits of the paper, an article. It doesn't have to be the whole paper, but you might find something. Just picking key things that are interesting. Communicating quiet environments. It's really hard against the background noise if somebody's got a speech problem. I see sometimes, and I'm sure none of you do it, but when somebody has a speech problem, the other person sort of rabbits on at them, overcompensating, trying to deal with it. I think it's good to speak clearly, deal with one topic at a time, even if the person, it's not that they have no ability to understand these things, it just gets reduced and reduced as the disease condition continues. So if there is a language problem, the person is having trouble, keep the sentences short and the structure simple. Probably the age group here remember subject predicate, right? Do it in subject, verb, object structure. Much easier. Allow time for communication. That's not always easy, but sometimes people, when they're caring, they've got the things that they can just do. They've sorted that out, and then there's the time for communication. And have material that triggers communication. There. Now, the problems that I've described in this talk are just an outline, and although these conditions have typical features, it's not the same, as I said, combination with every person. And you have to work out what issues you've got. It's very important that to deal with what the person is experiencing, that everybody's an individual. And because we all differ as people, we all have different communication styles to start with. We're not going to make somebody who hardly ever talked start chatting because they go to speech pathology. So we have to, as a basis, have that person and where they're at and what they're interested in and what their communication style is as the basis of how we approach it. Okay, so that's really all I've got to say, but I'm quite interested if people have